This talk is about vascular brainstem syndromes. It will be conducted in a question and answer format. First question: which of the following statements regarding major vascular brainstem syndromes classification is not true? A. Vertical labeling is based on brainstem divisions. B. Horizontal labeling is based on medial or lateral locations. C. Includes unilateral and bilateral pathologies. D. Is based on the types of pyramidal tract findings. Major vascular brainstem syndromes classification vary from book to book. I will present the one I have found most useful. It includes bilateral and unilateral entities. Among the bilateral entities, we have those involving the ventral pons and the dorsal midbrain. Among unilateral entities in the midbrain, we have medial and lateral syndromes, in the pons, medial and lateral syndromes, and in the medulla, medial and lateral syndromes. So the answer to this question is D. Next question. The eponym for lateral medullary syndrome is Dash syndrome. A. Parinaud. B. Marie-Foix. C. Dejerin. D. Wallenberg. E. Weber. F. Benedict. In this frame, you can see a brainstem with all its cranial nerve originating from the left side. We will use this figure to visually organize the vascular brainstem syndromes. Vascular brainstem syndromes have an anatomical name and an eponymic label. Those that result from midbrain involvement include the dorsal midbrain syndrome, also known as Parinaud syndrome, the medial midbrain syndrome, also known as Weber syndrome, and the lateral midbrain syndrome or paramedial midbrain syndrome, also known as Benedict syndrome. Those in the pons are called the ventral pontine syndrome, also known as Locking syndrome, the medial pontine syndrome, also known as Foville syndrome, and the lateral, also known as Marie-Foix syndrome. Those in the medulla are called the medial medullary syndrome, also known as Dejerin syndrome, and the lateral medullary syndrome, also known as Wallenberg syndrome. So the answer to this question is D. Next question. Involvement of the anterior spinal artery occurs in Dash syndrome. A. Parinaud. B. Marie-Foix. C. Dejerin. D. Wallenberg. E. Weber. F. Benedict. This table, color matched with the brainstem cartoon, lists the arteries involved in the different major vascular brainstem syndromes. We will mention each syndrome followed by the involved artery. Weber is due to blockage of the posterior cerebral artery penetrating branches arising from P1. Benedict is due to blockage of the posterior cerebral artery penetrating branches arising from P1 or P2. Foville is due to blockage of paramedial branches of the basilar artery. Marie-Foix is due to blockage of the anterior inferior cerebellar artery. Dejerin is due to blockage of the anterior spinal artery arising from the vertebral arteries. Wallenberg, also known as Pica syndrome, is due to blockage of the posterior inferior cerebellar artery. Parinaud is due to blockage of the collicular or quadrigeminal artery. Locking syndrome is due to blockage of the basilar artery. So the answer to this question is C. Next question. Which of the following cranial nerve motor nuclei is not in the brainstem medial region? A. Cranial nerve 4. B. Cranial nerve 3. C. Hypoglossal nucleus. D. Abducens nucleus. E. Ambiguous nucleus. 4 cranial nerve nuclei are considered medial. In this cartoon, the area between the interrupted lines constitute the medial region. In it, we will find the following nuclei. Cranial nerve 3 and 4 are in the midbrain. Notice that cranial nerve 4 nucleus is opposite to its nerve anterior trajectory. Cranial nerve 6 nucleus is in the pons, and cranial nerve 12 nucleus is in the medulla. So the answer to this question is E. Next question. The fibers originating from the dash curves in the medial brainstem region. A. Nucleus ambiguus. B. Dorsal motor nucleus of the vagus. C. Motor nucleus of the facial nerve. D. Superior salivary nucleus. E. Inferior salivary nucleus. In this brainstem sagittal figure, you can see the cranial nerve nucleus housed in the medial region and their fibers. I have now added the motor nucleus of the facial nerve and its fiber. I have done so to emphasize that the facial motor fibers are present in the brainstem medial region, as we can see in the block brainstem image just added. Notice that the fibers of cranial nerve 6 and 7 travel through the area occupied by fibers from the pyramidal tract. So the answer to this question is C. Next question. An unilateral nuclear lesion of cranial nerve dash will produce bilateral findings. A. CN4, B. CN6, C. CN3, D. CN12. The nucleus of cranial nerve 3 is made of different subnuclei. As you can see, fibers from the superior rectus subnucleus cross the midline to innervate the superior rectus on the other side. The levator palpebrae subnucleus is central. It provides innervation to both levator palpebrae. So the answer to this question is C. Next question. Which of the following cranial nerve motor nuclei damage produces contralateral eye worsening of upward eye deviation upon lateral gaze to the side of the normal eye? A. Cranial nerve 4, B. Cranial nerve 6, C. Cranial nerve 3, D. Cranial nerve 12. Damage to the perinuclear region of the third cranial nerve produces ipsilateral eye down and out deviation on primary position, pupillary dilatation, and ptosis. Damage to the nucleus of cranial nerve 4 produces diplopia and elevation of the contralateral eye in primary position. Both worsen upon lateral gaze towards the side of the normal eye. Damage to the nucleus of cranial nerve 6 produces ipsilateral eye inward deviation on primary position. Damage to the nucleus of cranial nerve 12 produces ipsilateral tongue weakness and ipsilateral tongue deviation with lingual protrusion. So the answer to this question is A. Next question. Which of the following structures is in the medial region of the medulla and pons and laterally located in the midbrain? A. Medial lemniscus, B. Medial longitudinal fascicle, C. Spinothalamic tract, D. Sympathetic tract. In this frame, you can see the most salient clinical manifestation of medial cranial nerve nuclear and perinuclear damage. These findings, in addition to indicating medial region pathology, they contribute to vertical localization. Further localization of a vascular lesion requires knowledge of other elements. These elements can be divided in those localized to the medial brainstem region and those housed laterally. Among medial region elements, we have the medial longitudinal fascicle, damage produced inability to adduct the eye ipsilateral to the lesion when looking to the side opposite to the lesion, and adduction nystagmus in the normal eye. Notice the green and red arrows. The segment of the fascicle hosting this function is only present at the level of the pons and midbrain. Next, in the medial region, we have the pyramidal tract, which in the midbrain rostral region expands beyond the medial region into the lateral region, as presented here and schematically represented in this new frame. Notice the lateral migration of the pyramidal tract, medially at the level of the medulla, slightly lateral at the level of the pons and midbrain boundary, and lateral in the upper midbrain. Damage to these fibers in the midbrain produces contralateral hemiparesis and weakness of the lower face quadrant. Lesions in the pons or medulla produce contralateral hemiparesis but do not involve the face. The third medial structure we should consider is the medial lemniscus, which in the pons and medulla is in the medial region, but at the level of the midbrain is located in the lateral region. A point that you can clearly see in this cartoon. At the level of the medulla, the decussating fibers of the medial lemniscus are in the medial region, lateral in the upper pons lower midbrain region, and more so in the upper midbrain region. This tract is displaced laterally by the fibers from the contralateral cerebral peduncle in the lower midbrain and by the red nucleus in the upper midbrain. Involvement of the medial lemniscus anywhere in the brainstem produces loss of vibration, epicritic sensation, and position sense on the side of the body contralateral to the lesion. The next laterally placed important structure for localization is the sympathetic tract. The most noticeable manifestation of damage to the sympathetic tract is Horner syndrome ipsilateral to the lesion. Horner syndrome is characterized by ptosis of the upper and lower eyelids, miosis and anhidrosis, and flush appearance of the ipsilateral half of the face. Next, we have the spinothalamic tract. Damage to the spinothalamic tract translates in loss of pain and temperature discrimination in the body contralateral to the lesion. Damage to the spinocerebellar tract is dominated by ipsilateral ataxia. Next important laterally placed structure for localization is the sensory nuclei of cranial nerve 5. These nuclei, the spinal and main, occupy the lateral region at the level of the medulla and pons. Damage to the spinal nucleus produces ipsilateral loss of pain and temperature discrimination of the face. Involvement of the main nucleus theoretically produces loss of epicritic sensation in the same region of the face. The last structure I will mention is the sensory tract of cranial nerve 5. This structure is only present in the midbrain. It is constituted by the crossed fibers from the opposite sensory nuclei of the fifth. Thus, damage produces loss of pinprick and thermal discrimination, but in the contralateral side of the face. So the answer to this question is A. Next question. Which of the vascular midbrain syndrome is more likely associated with tremor? A. Weber, B. Benedict, C. Dejerin, D. Wallenberg, E. Parinaud, F. Marie Foix, G. Locked in, H. Fauville. In the next few minutes, we will address midbrain vascular syndromes. The syndrome described by Weber is not rare. Its manifestations are easily explained using this figure. Weber compromises the medial region of the midbrain, rostally, as delineated by the red area just added. Hence, it involves cranial nerve 3, the medial longitudinal fascicle, and the pyramidal tract. It does not involve the medial lemniscus because in the midbrain, this structure is displaced laterally. This MRI is consistent with the diagnosis of Weber syndrome. It shows a left medial rostral midbrain lesion. In this frame, I have added a brainstem figure. Mapped in red is the affected area, as you can see. In this new frame, I added the pictorial summary of the elements involved in Weber syndrome. Ptosis, mydriasis, and down and out deviation of the eye on the side of the lesion due to damage to the fibers of the third cranial nerve at the perinuclear region, inability to look in with the affected eye during lateral gaze due to medial longitudinal fascicle damage, and contralateral hemiparesis and lower quadrant facial weakness due to pyramidal involvement. Now let's turn the page to another syndrome. The syndrome described by Benedict involves the lateral midbrain rostral region, as depicted by the red area just introduced. It involves the third cranial nerve fibers that fan laterally from the medial located third cranial nerve nucleus. It spares the NLF but involves the pyramidal tract, the medial lemniscus, and the red nucleus. Other structures that may be involved in this syndrome are the central sympathetic tract, spinothalamic tract, and the ascending cranial nerve 5 sensory fibers after their crossing. Benedict syndrome may also involve the cross superior cerebellar fibers. This MRI is consistent with the diagnosis of Benedict syndrome. It shows a left lateral rostral midbrain lesion. The lesion is mapped in the added illustration. I have now introduced a pictorial summary of the elements involved in this syndrome. So we have ptosis, down and out deviation, and mydriasis ipsilateral to the lesion, contralateral hemiparesis, and lower quadrant facial weakness due to involvement of the pyramidal fibers in the lateral midbrain, loss of vibration, epicritic sensation, and position sense contralateral to the lesion due to medial lemniscus fibers involvement housed in the midbrain lateral compartment, contralateral tremor due to involvement of the red nucleus. In addition, patients with Benedict syndrome may have ipsilateral Horners due to involvement of the sympathetic tract, contralateral decreased pinprick sensation and thermal discrimination, which I have represented by adding purple dots to the crowded contralateral limbs in this frame due to spinothalamic involvement, hemifacial decreased pin and prick sensation and thermal differentiation due to involvement of the cross cranial nerve 5 sensory fibers, contralateral ataxia due to involvement of the decussated superior peduncular fibers. I will now take a few minutes to explain the location of ataxia in Benedict syndrome. In this new figure, you can see three elements: the block specimen in the middle, the corresponding histological cuts by the side to your right, and the human cartoon with a miniature block specimen indicating ataxia contralateral to the lesion. The site of the lesion is indicated by the red cross, the site of the ataxia by the yellow limbs. In the block specimen, we have a double crossing two-arm circuit. One arm of the circuit going from the cerebellum to the cerebral cortex, and the other arm from the cortex to the spine. The arm going from the cerebellum to the cerebral cortex is constituted by the dentorubral thalamic tract. This arm after having traveled ipsilaterally in the superior peduncle, decussates at the level of the lower midbrain as indicated here and here. The arm going from the cerebral cortex to the spine is the pyramidal tract. The pyramidal tract is represented in aqua. A lesion after the dentorubro-thalamic decussation indicated here in the blocky specimen and here in the histological specimen produces contralateral ataxia by the impact this crossing has on cortical function and the crossing of the pyramidal tract at the medulla. Now let's pass the page to learn about another syndrome. Henri Parinaud, a French neuro-ophthalmologist, described a series of patients with up-gaze palsy which he attributed to lesions of the quadrigeminal area. Currently, Parinaud syndrome consists of up-gaze paralysis, light near dissociation, lid retraction in the primary position, which is called Collier sign, convergence retraction, and convergent retraction nystagmus. So the answer to this question is E. Next question. Which of the vascular medullary syndromes spares cranial nerve 12? A. Weber, B. Benedict, C. Dejerin, D. Wallenberg, E. Parinaud, F. Marie-Foix, G. Locked in, H. Fauville. Let's first address Dejerin syndrome. Joseph Dejerin in 1914 in his book Semiology of the Nervous System drew or had someone else draw this cartoon, emphasizing an atrophic half of the tongue and its deviation towards the site of the lesion, as if licking its wound. In addition, the illustration showed shading on the side of the body opposite to the site of the tongue deviation, implying contralateral hemiparesis and impaired proprioception and vibration sense. Dejerin syndrome involves the medial medullary region as mapped by the red area. Thus, it affects cranial nerve 12, the pyramidal tract, and the medial lemniscus. The MLF is spared because it is not present in the medulla, or at least not involved in lateral extraocular movements at this level. In this frame you can see an MRI. This MRI shows a left medial medullary lesion consistent with Dejerin syndrome. In this frame I have added the cartoonish representation of the lesion, and in this new one the pictorial summary of the syndrome. The tongue deviation towards the lesion occurs because of ipsilateral tongue weakness due to cranial nerve 12 involvement, and on the side contrary to the lesion we find hemiparesis with no facial involvement due to pyramidal tract involvement, and diminished vibration sense, epicritic sensation, and position sense due to medial lemniscus involvement. Now let's turn the page to another syndrome. Everyone agrees that it was not Wallenberg, but Gaspard Vissou, who first described Wallenberg syndrome. For that reason, and for having described the symptom of the disease having had it himself, you would think that this condition would carry his name, but it does not. Be it as it may, Wallenberg syndrome, as you know, affects the lateral medulla, as mapped in this frame by the red area. It spares cranial nerve 12, but involves the sympathetic tract, spinothalamic tract, spinocerebellar tract, and spinal nucleus of cranial nerve 5. In this frame, I have removed cranial nerve 12 to introduce other structures involved in this syndrome: the vestibular nucleus, the central tegmental tract, nucleus ambiguus, and nucleus solitarius. This MRI shows a left lateral medullary lesion typical of Wallenberg. The location is mapped in this cartoon. I have now added the pictorial summary of this syndrome. Ipsilateral Horner due to involvement of the central sympathetic tract, contralateral loss of pain prick sensation and thermal discrimination due to spinothalamic tract involvement, ipsilateral ataxia due to spinocerebellar tract involvement, and loss of pinprick sensation and thermal discrimination in the ipsilateral half of the face due to cranial nerve 5 spinal nucleus involvement. Nystagmus and vertigo due to vestibular nucleus involvement often occurs. Damage to the nucleus ambiguus produces dysphonia, dysarthria, dysphagia, and intractable hiccups. Damage to the nucleus solitarius produces lack of taste and cardiac arrhythmias, fatal if untreated. Damage to the central tegmental tract causes palatas myoclonus. So the answer to this question is D. Which of the vascular pontine syndromes involves the internal facial nerve genu? A. Weber, B. Benedict, C. Dejerin, D. Wallenberg, C. Parinaud, F. Marie-Foix, G. Locked in, H. foveal. This trio describes Merry-Foix syndrome. This vascular brainstem syndrome involves the lateral pons, as mapped in this frame. It damages the sympathetic tract, spinothalamic tract, spinocerebellar tract, the sensory nuclei of cranial nerve 5, the facial motor nucleus, and the vestibular nucleus. This MRI shows a left lateral pontine lesion typical of Merry-Foix syndrome. The location is mapped in this cartoon. You can see the elements involved in the pictorial summary and thus predicts its clinical manifestations. The symptoms of Merry-Foix include Horner's syndrome ipsilateral to the lesion due to central sympathetic tract involvement, contralateral decreased pinprick sensation and thermal discrimination due to spinothalamic tract involvement, ipsilateral ataxia due to spinocerebellar tract involvement, ipsilateral loss of pinprick sensation and thermal discrimination in the ipsilateral phase due to sensory nuclei of cranial nerve 5 damage. Of great localization value is the presence of facial nerve palsy, which indicate facial pontine lesion. Patients with Merry-Foix syndrome may also have nystagmus and vertigo due to vestibular nucleus involvement. Before dropping the subject of Merry-Foix syndrome, I'd like to say a few words about the lateralization of ataxia associated with this syndrome. This is the same drawing I used to explain the lateralization of ataxia in Benedict syndrome with a few significant differences. The dentorubral thalamic tract is originated from the right and the pyramidal tract from the left. And in the human cartoon, you see ipsilateral ataxia. Notice the site of the lesion in relation to the ataxia. I have now added a histological specimen of the pons. I will now add the pontocerebellar fibers first to the block specimen, those going from the left pons to the right cerebellum, and in the pontine histological specimen, those from both sides. I have now represented a lesion on the right side of the pontocerebellar fibers after the decussation, using the same reasoning we used to explain contralateral ataxia in Benedict syndrome. We can see why such a lesion, in the case of Merry-Foix, produces ipsilateral ataxia. After the pontocerebellar fibers decussate, the dentatorubro-thalamic tract also decussates, and so does the pyramidal tract. Hence, after a right pontine lesion damaging the decussated fibers from the left pontocerebellar nuclei, ataxia will occur in the right side of the body. Now, let's turn the page to another syndrome, the syndrome described by foveal. It involves the medial region of the pons as depicted here. Damage to this area leads to cranial nerve 6, medial longitudinal fascicle, pyramidal tract, and medial lemniscus, and the pontine nuclei, a cluster of neurons in the brainstem that relay information from the cerebral cortex to the cerebellum. It also affects the facial motor fibers as they travel back to encircle the nucleus of the 6. I am showing you this specimen to give you a better anatomical perspective of pontine lesions. In this specimen, we can see the relation between the just mentioned structures. The pontine fibers in pale blue, these are the fibers from the pontine nuclei of one side going to the opposite middle cerebral peduncle. The pontine nuclei in pink white, the source of the pontocerebellar fibers, the nucleus of the abducens, the fibers of the abducent nerve, the facial nerve fibers, most of them on the way to the muscles of expression, the internal genu of the facial nerve, and the nucleus and tract of cranial nerve 5. So, as you can see, facial nerve palsy can occur with a medial lesion, in which case will be associated with abducent palsy, and with lateral lesion, in which case it is associated with sensory signs related to cranial nerve 5 damage. This MRI shows a left medial pontine lesion characteristic of foveal syndrome. The location is mapped in this cartoon. I have now added a pictorial summary of the elements involved in this syndrome to discern its clinical manifestations. Diplopia in primary position due to ipsilateral weakness of the lateral rectus, resulting from cranial nerve 6 involvement. Inability of the affected eye to look in during lateral gaze in the opposite direction due to MLF involvement, contralateral hemiparesis due to pyramidal tract involvement, contralateral loss of vibration sense, epicritic sense, and position sense due to damage to the medial lemniscus, ipsilateral peripheral facial palsy due to damage to the facial nerve fibers as they encircle the 6th cranial nerve, ipsilateral ataxia due to interruption of pontocerebellar fibers traveling from the opposite intact side of the pons. Now, I'd like to introduce an interesting case. These images are from a teaching video, case of foveal syndrome. You may want to see it after this talk. The patient has normal right gaze but is unable to look to the left. This finding is consistent with a left parapontine reticular formation damage. He has a right hemiparesis consistent with pyramidal tract involvement prior to decussation. The MRI shows a pontine bleed expanding to the left. So the answer to this question is H. Next question. Which of the statements about classical locked-in syndrome is not true? A. Liz is characterized by quadriplegia with preserved vertical eye and eyelid movements and retained cognitive abilities. B. Liz occurs due to damage to the ventral pons. C. The most common cause of Liz is a stroke affecting the basilar artery. D. Liz involves the dorsal pontine tegmentum. This is a photograph from the BBC of a patient with locked-in syndrome. As you can see, the patient's eyes are open. An EEG is being recorded and eye movements are being monitored. The manifestation of locked-in syndrome occurs due to damage to the medial region of the pons anteriorly, mapped here. The damaged area contains the pyramidal tract on each side of the midline. The fibers from cranial nerve 6 and 7th bilaterally, as shown here, by the red area involving both abducens and facial nerves. I'd like to stress that on this figure, the facial nerves are drawn more medial than usual. These MRI findings are consistent with the diagnosis of locked-in syndrome. You can see a lesion involving the basis pontis and sparing the tegmentum. As you can see, the patient looks alert, mentation is normal, communication is restricted to up and down eye movements and eye opening and closing, which is achieved by gravity to close the eyes and contraction of the levator palpebrae and muscle of Mueller to open them. So the answer to this question is D. Before you go, I want to mention one more syndrome, the top of the basilar artery syndrome. This syndrome manifests by signs of midbrain, subthalamic, and paramedial thalamic area damage. Hence, it often presents with sudden decreased level of consciousness due to the usually bilateral involvement of either the reticular formation or of the thalamus and symptoms of Weber, Benedict, and Parinaud. Thank you very much for your attention.